I am Dr. Ruth Michaelis, and I'm a family physician at Health Point Community Health Center in Washington State. I am also faculty at the A.T. Still University School of Osteopathic Medicine in Arizona, which embeds students in community health centers for their last 3 years of medical school. The patient experience has eclipsed many other measures in our quest for healthcare quality improvement, as it is linked to both healthcare outcomes and patient satisfaction. Healthcare leaders are prioritizing the patient experience through laws like the Affordable Care Act to change the direction of reimbursement from quantity to quality. Patients have long filled out patient satisfaction surveys, which actually do correspond to places that provide better quality of care, not just to patients recommending their doctor to family and friends. But patient surveys often just allow us to compare services against our goals and don't always provide direction on how to improve. In order to improve the patient experience, we have to continuously identify and subsequently resolve issues by addressing fundamental processes within the organization. One of the tools with which to address these processes is through lean methodology. Here are the scholars' projects focusing on improving patient experiences.
My name is Ariane Cordon, and I am a fourth-year student at Northwestern Feinberg. I spent the last 6 weeks at Orange Blossom Family Health in Orlando, Florida, and my project is titled The Role of Behavioral Health in Improving Glycemic Control in Patients with a Dual Diagnosis of Diabetes and Depression. Diabetes is a prevalent condition, particularly affecting vulnerable populations such as those from low socioeconomic statuses and minority groups. Literature has shown that diabetes is a risk factor for developing depression, and that consequently, depression can have negative physiologic and behavioral effects on a patient's glycemic control. Literature has also shown that interventions targeted at addressing both diabetes and depression in an integrative fashion have resulted in improvements in both these conditions. The objective of this study was to test this premise in assessing whether behavioral health is associated with the lower hemoglobin A1C average in patients with a dual diagnosis of diabetes and depression. The first part of the analysis compared the average A1C values in patients seeing behavioral health to their counterparts not seeing behavioral health. The second part of the analysis compared the A1C values in the same patient group before seeing behavioral health versus after seeing behavioral health. First, an intervention group was established by identifying patients with a diagnosis of depression and diabetes who saw behavioral health more than once and recording their A1C values before they started seeing behavioral health. These were known as the pre-behavioral health values, and at least 3 months after they started seeing behavioral health. These values were known as the post-behavioral health values. Then, a control group was established by identifying patients that also had a diagnosis of diabetes and depression, but who never saw behavioral health and recording their respective A1C values. In the end, the intervention group consisted of 27 patients and the control group consisted of 26. In regard to the first objective of the study, patients in the post-behavioral health group had a lower A1C average compared to the control group, although this difference was not statistically significant. In regards to the second objective, patients in the same group had a lower average A1C after seeing behavioral health compared to before seeing behavioral health, but again, the difference was not statistically significant. Given the limitations from the small sample size and other confounding factors, this positive trend proves promising that treating depression of patients with diabetes with behavioral health visits may improve the patient's glycemic control. This potential highlights the importance in providing interdisciplinary care for complex patients, such as those with diabetes and depression, in order to optimize their medical management and behavioral changes that can affect both conditions. Thank you for listening.
Hello everyone, my name is Eric Covert. I'm going to be a second-year PA student at Rutgers University and just want to tell you some about my PCLP project. The title is Time is Money, but in healthcare it's not that simple. Current state rooming practices and the impact that intervention has using lean philosophy. So the objective of my project was basically to understand the standard state at the Health Point Community Health Center, specifically at the Redmond Clinic, And what we did is we implemented a intervention using lean methodology. And lean methodology is a form of quality improvement that was introduced in the automotive industry in the 19th century, in the 20th century, and popularized in medicine by the Virginia Mason Medical Center in Seattle. So what that kind of does is they have a model called the PDSA, Plan, Do, Study, Act. So what we used in our plan, the methodology for this project, was to answer a few questions. And that was starting as, what is the lead time and current cycle times for a patient visit when an MA makes the initial patient encounter? That's the current state. The second question we wanted to ask was, does the lead time and cycle time vary when an RN makes the initial patient encounter? And finally, if disparities are found, what are the implications? So in trying to answer those questions, I actually did timings of those cycle times. So I physically had a stopwatch and followed MAs and RNs around and recorded those times. When all the data was collected, I tried to put it together. It was a small sample size, unfortunately, but hopefully some meaningful data came from that. We did see a varying degrees of difference in the cycle time. So the kind of key findings are, when an MA versus an RN room the patient, the visit usually took 5 minutes and 35 seconds longer when an RN made the initial patient encounter. When the RN made the initial patient encounter, the patient would always wait about 5 minutes and 12 seconds longer for their PCP, primary care provider, to arrive. But then also when the patient was seen by the primary care provider, they often had only 3 minutes and 14 seconds less time with the primary care provider, which this equated to about a lead time for the patient of 7 minutes and 42 seconds longer of a wait time. And so the benefits we have for the RN intervention, the PCPs save time. They save 3 minutes and 14 seconds per visit, which equates to about 30 to 60 minutes per day. So they could see more patients in a day. Also, the patient has more value-added time with the RN seeing them rather than an MA. That they have a greater deal of expertise and they can be more assistance to the patient possibly than an MA might be. A couple of drawbacks. The patient, the lead time, the actual visit time does increase by 7 minutes and 42 seconds. And the waiting time in the room increases by 5 minutes and 12 seconds. So that's meaningful time that the patient could be doing something else, that no one wants to wait more or less or have extended length of time. So that could lead to patient satisfaction levels possibly dropping. Another drawback is the fact that patients are actually in front of their primary care providers 3 minutes and 14 seconds less, which is important. They look at their PCPs as their medical authority, and they want to have as much time in front of them as possible. So basically, the study was just an exploration of the current state, and just to do a hypothesis and test what that intervention might be with the nurse rooming the patient rather than an MA. And some of the results hopefully will just help guide leadership. It is a delicate balancing act for them to decide how to do their scheduling and cost-benefit analysis, those sorts of things. So as we say in many businesses, time is money, but I think this project made it pretty clear that in healthcare, it's not always that simple. So I thank you for your time today. All the best. Take care.
Hello, my name is Raleigh Fatoki, and I am a second-year medical student at Meharry Medical College. This summer, I participated in the GE NMF Primary Care Leadership Program, and I was placed at Neighborhood Health in Nashville, Tennessee. Neighborhood Health is a network of community health centers serving the Nashville metropolitan area since 1976. The organization has grown from 2 clinics located in an old house in South Nashville and a public housing apartment in the Robert J. Casey homes to a network of 11 clinics providing in excess of 90,000 visits to over 25,000 patients each year. My independent service learning project assessed patient satisfaction with neighborhood health clinic visits. The goal was to compare neighborhood health patient satisfaction to community health centers nationwide to determine if patients are satisfied with their overall level of care, staff friendliness, timeliness of appointment, and patient ratings of their providers. Surveys were offered to patients after office visits at 3 neighborhood health clinics during June and July of 2015. The survey was based on the Consumer Assessment of Healthcare Providers and Systems Survey developed by the U.S. Department of Health and Human Services Agency for Healthcare Research and Quality. Data showed that neighborhood health scored in the 90th percentile for timeliness of care compared to community health centers nationwide. This is extremely significant because the Department of Health and Human Services Southern Region, which neighborhood health is a part of, ranks as the lowest of all regions nationwide in getting patients timely appointments. Neighborhood health also ranked 90th percentile in staff friendliness and quality of providers. Moving forward, there are opportunities to explore the social factors that negatively impact patient health. Neighborhood Health's East Side Clinic seems to be doing the best job of asking patients about factors that make it difficult to improve their health, but there are still opportunities to dig deeper into these non-medical health determinants at other clinics. It is also recommended that Neighborhood Health implement a Spanish language survey to better measure Latino patient satisfaction. This project was unable to survey a significant number of Latino patients because of a language barrier. In closing, I would like to thank a few people and organizations that made this project possible. They include the GE Foundation, National Medical Fellowships, Neighborhood Health, the Meharry Vanderbilt Alliance, Meharry Medical College, Dr. Mary Buffwack, Pam Brilhart, and Dr. Dave Carrier, Katie Hill, as well as the front desk staff at the KC Eastside and Edge Hill clinics. Thank you.
Title of this project is Analyzing Southside Medical Center's Mobile Unit Health Fairs and Patient Follow-Up and Patient Satisfaction. I'm Theodore Harper, a rising second-year medical student at Southern Illinois School of Medicine. The site placement took place at Southside Medical Center in Atlanta, Georgia. The objective of this project was to 1. Assess the patient satisfaction by administering a 10-question survey, and 2. To determine the rate of patient follow-up in Southside Medical Center associated clinics from health fairs by looking at a retrospective analysis from November 1st, 2014 to June 30th, 2015. The results support the benefits of mobile health units and health fairs administered by Southside Medical Center. The methods included a cross-sectional survey which was conducted to test patient satisfaction with mobile unit health services. The survey consisted of a 10 multiple choice question assessing the rating, marketing, and plan of utilizing the information. It was conducted at a health fair at Bethel Baptist Church in association with the Southside Medical Mobile Unit on June 27 and administered to a convenient sample of 33 participants. A retrospective data analysis was done to analyze the rate of patient follow-up in community health centers from Southside Medical Center's previous health fairs. A database of patient demographics, including gender, method of payment, and types of services utilized upon follow-up, was analyzed from November 1st to June 30th, 2015. This included all mobile unit and health fair events from this time. The key findings: 33 surveys were administered at Bethel Baptist Church Health Fair on June 27th. Overall, the majority of the patients rated the health fair as excellent, with only 2 out of the 33 participants rating it as fair. When participants were asked why did they attend the health fair, the majority of the responses was because it was free and they were curious about their health. Approximately 20 participants stated that they planned to read more information that was provided at the health fair. 10 participants planned to share information from the health fair. 4 discovered a new diagnosis, and 3 planned to see a physician. When 562 participants were analyzed from November 1st, 2014 to June 30th of 2015, 14 returned for dental services. 5 participants returned for both the mobile unit and to the main center for adult medicine and family practice services. 4 participants returned to specialty optometry services, and 2 participants returned to the Women's Center. When the form of payment was analyzed for participants' return, 67% was by self-pay, 20% was by Medicaid managed care, and 13% was by commercial pay. The recommendation: Southside Medical Center should utilize their mobile unit more. It's a great way to advertise Southside Medical Center's services, possibly twice a month, targeting counties with a large uninsured population. They should also make phone calls to ensure that patients who intended on following up understand the importance of their results. They should also assess the dental team's approach of customer service and satisfaction, as well as targeting female services, since they have the largest turnout. Lastly, there should be more information provided for the uninsured about the available options, such as a sliding fee scale. Thank you.
Hi, my name is Nathan Lynn. I go to the University of Illinois College of Medicine. I was placed at Anthony Jordan Health Center in Rochester, New York this summer for the Primary Care Leadership Program. My project is entitled Understanding Refugee Healthcare, a View from Patients, Providers, and Staff. Basically, the objective was to provide both qualitative and quantitative data to assist Anthony Jordan Health Center as they develop practice transformation in particular for the refugee health program at one of their clinics called Brown Square. I went about doing this by conducting 24 semi-structured interviews of refugee patients. Refugees were from Burma, Somalia, Vietnam, or Russia / the Ukraine, and all the interviews were conducted with the assistance of in-person interpreters who work at Brown Square. I also conducted 8 interviews of staff members in the refugee health program to get a feel for their thoughts on the program. Key findings included basically discovering the value of, or affirming the value of, having in-person interpretation for the quality of care provided to the refugee patients, and also the importance of having in-house services specific to the refugee health program. Some recommendations that I have are essentially how to reconcile the different cultural backgrounds that come together in the clinical encounter, the importance of checking one's cultural biases and expectations, and encouraging the interpreters to take on the role of bridging the gap between provider and patient, and the different cultural expectations that are brought to the clinical encounter, as well as considering patient education about the norms and standards in the United States healthcare system. Another realm of recommendation is within the interpretation services, the importance of having more interpreter training to increase their confidence and competence, and as well as hiring a Nepali interpreter, because a lot of new refugees coming to Rochester are Nepalese. Refugees also face a lot of barriers to navigating the very complicated United States healthcare system. And I think having direct phone lines to the interpreters in order to facilitate setting up appointments would be helpful. A lot of miscommunication occurs because of the language barrier. Having more in-house services such as mental health, behavioral health, and social work specific to refugees would be helpful, so that the provider does not need to refer the refugee patient outside of the clinic, because that is a source of a lot of breakdown of care. Having more training specific to refugee care in order to assist different roles, for example, the nurses, to practice at the top of their capacity. and more education programs just in general to increase health literacy and self-advocacy of the refugee patients. And then finally, another realm is that of outside of the walls of Brown Square, namely how to strengthen relationships with other organizations in Rochester that are already providing services to refugees, how to share resources with these organizations, specifically the ones that are dealing with refugee health. Getting a better feel for what are the needs and the desires of refugees out in the community and how can Brown Square cater to these, and simply advertise the existence of this refugee health program. But in conclusion, I think the program has a lot of assets, is doing a lot well, namely just showing respect and having a lot of experience working with refugee patients, and this primarily, along with the in-person interpretation, is what continues to bring patients back to Brown Square. Thank you.
Hello, my name is Natalie Reyes, and I'm reporting on my project titled Assessing, Managing, and Improving Patient Care at the Watts Health Center, Implementation of the CAP Survey. Quality healthcare is an issue that we face as a nation every day. More recently, our healthcare system has moved towards adopting a patient-centered care model. It is important to assess and understand patient satisfaction from the patient's perspective in order to determine how to improve quality health care. The Watts Health Center is a federally qualified health clinic that strives to serve quality patient care to a predominantly underserved community in Los Angeles, California. The main objectives of this project were to be able to assess the quality of patient care from the patient's perspective through administering this survey throughout the clinic. Thus, through this study, we look forward to improving the quality of patient care at the Watts Health Center by identifying areas of patient concern through the CAPS Patient Satisfaction Survey, or the Consumer Assessment of Health Providers and Systems Survey. Through data analysis, this study is able to determine areas for clinic improvement that will improve quality care for the community that Watts Health Center serves. Methods. Prior to 2015, the Watts Health Center was measuring patient satisfaction based on a short 5 to 10 question survey. This year, the CAP survey was implemented as a way to maximize efforts in meaningful data collection and analysis. The CAP survey has a total of 37 multiple-choice questions asking about patients' experience in the clinic, accessibility to care, staff interactions, and demographic information. Given that the clinic sees a predominantly English and Spanish-speaking population, the survey was created in both languages. The survey was administered via paper within the waiting rooms of the primary care clinics, adult medicine, pediatrics, and obstetrics and gynecology. Surveys were collected on a daily basis, Monday through Friday, at various times. Data was recorded and analyzed using Microsoft Excel. Key findings. A good proportion of the clinic's patients are returning over 4 times annually, whereas the national average of visits is roughly 3.3. Thus, it appears that the Watts Health Center patients are returning to the clinic much more frequently than the rest of the nation. But why? Because the clinic serves a disadvantaged population, is it appropriate to assume the clinic sees a sicker population that requires more frequent and acute care? Are patients not receiving sufficient care in one visit and thus have to return more frequently? It is more than evident that the clinic is lacking tremendously in maintaining given appointment times, leading to a long waiting room time. Patients mention that they sometimes wait 1 to 2 hours after their appointment times. The clinic has a large no-show rate for patients and often double book 2 patients. If both patients show up, however, it puts pressure on the provider to hurry through each appointment. And once a provider is delayed with 1 patient, this affects the rest of the daily schedule. Patients are satisfied with the provider's ability to listen and explain things in an understandable manner. Watts Health Center staff is doing a great job at creating an environment where patients are feeling heard and well cared for. Most patients are rating their provider with a score of over 7 out of 10, recommending their provider, which demonstrates overall satisfaction and trust with their healthcare system. Few patients surveyed, however, did give their provider a score of 6 out of 10 or lower, saying they would not recommend their provider. It is important to determine why these patients are dissatisfied with their care. One patient explained the clinic needs to treat the people better. The doctor is excellent, but the rest need to treat the people better. This was translated from Spanish. It is important to note that the patient is a Spanish speaker, and it is possible that the dissatisfaction with the staff in this situation could be an example of language and cultural barriers. Almost half of surveyed individuals were of Hispanic and Latino descent. This example shows the importance of having an adequate amount of staff to address various language, cultures, etc. Recommendations. Determine a more appropriate and effective way to implement patient satisfaction surveys if using the CAP surveys. The survey was way too long to administer in a time-efficient manner in waiting rooms. More time is thus recommended for this project to develop a larger sample size, making the data more significant. Compare our CAP survey results with a national database. It is also important for the clinic to address the issue of waiting room times. It is clearly important to patients that the clinic respect given appointment times in order to improve patient satisfaction. Finally, it is important to train staff in cultural competence in order to address the clinic's specific demographics. Thank you.
Hello, my name is Arnold Istanbul, and I am an MD candidate at New York Medical College. This summer, I was placed at the Anthony L. Jordan Health Center in Rochester, New York. My summer project consisted of 2 objectives. The first was to conduct semi-structured interviews on Spanish-speaking patients to assess their experience and overall satisfaction with the time they spent at the health center. The second was relaying this information back to the site to help them understand both the patient's needs and wants, and will allow the site to work on making changes to enhance patient satisfaction and experience and benefit the site as it prepares for the shift to value-based payments. The research design consisted of semi-structured interviews conducted on a small group of Spanish-speaking patients to gather information about their satisfaction and experience while at the site. Patients were also given a short quantitative survey at the end, which asked about their overall satisfaction with their clinic visit. The study was done at the Brown Square Health Center located in Rochester, New York. The study participants consisted of willing Spanish-speaking patients with little to no English proficiency. Data from the interviews was obtained and noted in an Excel sheet to allow for quick comparison between patient responses. Afterwards, the data was analyzed via template analysis to identify major themes. There were 3 key findings. The first was that the expansion of the site should include an on-site social worker and radiology services. The second was that in-person interpreters are strongly preferred by the Spanish-speaking patients. Lastly, the Spanish-speaking patients at Brown Square are extremely satisfied with their experiences at the clinic. Out of 5, their rating average was a 4.63. Since the satisfaction scores and most of the responses were positive, it is recommended that the site continue doing what they are doing, only with some minor enhancements. First, in-person interpreters should be reinstated and incorporated into the 2016 budget. Second, hiring bilingual nurses to care for these patients would boost satisfaction and make for better experiences. Third, there is a need for consideration of expansion of the services provided, primarily having a social worker on site. Lastly, it is important to continue to search for and hire clinicians who speak Spanish.
This project focused on HealthPoint's call center. The objectives for this project included identifying barriers to workflow and patient care by analyzing call types and lead times and determining common issues within the current state of services. Ultimately, after recommending appropriate implementations, we expect to see a decrease in workload, a decrease in the amount of times patients call into the call center regarding the same concern, an improvement in workflow efficiency, and an improvement in overall quality of care and both patient and staff satisfaction. Over the course of 6 weeks, I documented call types and corresponding lead times to identify the most common call type, assessed barriers to workflow based on research and observation at both the call center and clinic back offices, conducted a staff survey to determine a common barrier to staff workflow and clinic protocol, and used comparative and graphical analysis to interpret data. The barriers I found included technical defects, such as an inaccurate phone tree queuing system, lack of specialized call center agents, lack of mistake-proofing feedback within the electronic health record system, and inconsistent protocols and standardized guidelines. What I proposed is to reconfigure the phone system's interactive voice response menu, submit a request to the electronic health record management system to link patients' records to a caller identification feature to help reduce call times, submit another request to issue a tasking alert pop-up to reduce mistakes, and to assign specific call center agents to individual clinics in order to establish and familiarize staff with appropriate guidelines and protocols, and essentially reduced everyone's workload. This last implementation appeared to be the most popular request based on the survey feedback due to agents being responsible for a significant amount of varying protocols. Overall, this project brought great insight to HealthPoint's current state, and they look forward to making the appropriate changes to improve the quality of patient care.